My name is Dr. Tabrizi. I'm an assistant professor at the University of Texas School of Dentistry, Department of General Practice and Dental Public Health. My focus is teaching geriatric dentistry to our students. The University of Texas School of Dentistry is one of the few dental schools in the nation that is committed to educate dental and dental hygiene students in improving oral health in older Americans. I will be happy to answer any of your questions regarding these presentations by contacting me through the information provided. Neither I nor members of my immediate family have any financial relationship with commercial entities that may be relevant to this presentation. Also, the opinions expressed in this presentation are those of the speakers and not necessarily those of the University of Texas School of Dentistry at Houston. The opinions expressed in this course should not be construed as advice to care for a specific patient. The objectives include definition of aging, growth of aging population, oral health status of the aging population, connection between oral health and other chronic diseases such as cardiovascular disease, diabetes, and renal failure. We also be talking about oral health preventive measures like primary and secondary preventive measures and silver diamond fluoride. We will mention nutrition and oral health of the elderly, enhancing quality of life for the aging population. Our oral health providers train for the generation of the baby boomers today. We will find that out at the end of the CE. Aging defines as a persistent decline in age-specific fitness components of an organism due to internal physiological degeneration. Oral health defines as a functional, structural, static, physiological, and psychological state of well-being, and is essential to an individual's general health and quality of life. So now you can see how the process of normal aging can affect oral health in every aspect, and as a result, very well connected to the state of overall health. Generation of baby boomers began turning 65 in 2011, and by 2050 they will be over 85 years of age. Elderly population in 2012 was 43.1 million, approximately over 13% of U.S. population. By 2050, this population would rise to 83.7 million, that is approximately 27% of U.S. population. On a side note, the generation of baby boomers will be the first group of individuals who will keep their natural teeth over their entire lifetime. Looking at the growth of population of elderly from 1900, when the life expectancy was 47, to 2050, which will rise to 84 years of age. The population naturally went from 3 million to a projected number of 88 million, and the percentage of 4% will rise to 20%. That is a huge increase since 1900. This graph shows that the fastest age group increasing is 85 and older. Another reason of once individuals turn 65, again due to advancement of medicine, they tend to live longer, 20 years and plus. So the 85 years old, that group is accelerating more than any other age group. And also, for the first time in the history of geriatric population as elderly 65 and older, it's not just the number of individual expanding, but it's also the diversity among them. Again, as we look at the chart and history, in 1900, majority of elders were white individuals, and if you look at into 2030, the diversity has actually taken over racial inequality that has been the topic of a debate in the past 50 years. And that article is actually in 2007 has a very good description of this change in diversity in geriatric population. What makes diversity complex is because the childhood and youth years that individuals are exposed to as far as nutrition and healthcare is the foundation of their health, that it carries through lifetime, and a lot of times you still see the effect of those years as they get older. So the patients that we see as dental patients, they bring many years of health exposure, oral health exposure, according to the lifetime, that it is the operator's responsibility to recognize the diversity and have the diversity defines as a word that's something different to each and every person. And complexity is a Latin root with the word of coming together as gatherness in a woven form, describes the behavior of a system or model whose components interact in multiple ways and follow local rules. Now we can, with this definition have in hand, we can see how this diversity that has different meaning and complexity of our society that is woven with different elements can affect health and health outcomes. Complexity in older adults is an expression of 5 elements. First is the individual genetic predispositions, then its environment. That's where makes their health beliefs, and that becomes a very important in our communications with our patients, knowing what we say, it makes sense to them. Is their life experiences, is their socializations, and most importantly, lifestyle. Individuals' genetic predisposition is the hardware pattern of individuals' medical history and their background. So it's very important for us to take a comprehensive and accurate medical history, questions on parents and overall health and dentition, nutrition, everything there is, because based on that predisposition, that hardware pattern, we can expect some kind of proper outcome. Environment forms individuals' health beliefs, and based on their health beliefs, behaviors are made of. If we want to communicate properly with individuals who believe you go to a dentist only if you have a toothache, or they believe tooth loss after a certain age is normal, we have to understand their environment and their health belief in order to have a communication with them that it can change the behavior with a better outcome. The status of health in an elderly is an outcome of their life experiences. It's their childhood years, it's the youth years, it's that middle age years. It's all comes together. It has to do with their nutrition, with their food availabilities, and literature shows that the poorest oral health are those who are economically or at a disadvantaged. Early childhood years can lead individuals towards or away from healthy overall health and oral health. So looking at and bringing in the life experience as a part of your plan or expected outcome, it's crucial. Literature supports individuals with poor oral health tend to be more withdrawn and socially isolated. On the other hand, social isolation in elderly poses many health risks, including living alone, having a small social network, infrequent participation in social activities. The magnitude of health risk for social isolation is the same as smoking cigarettes and obesity. Healthcare providers are challenged by the complexity of the individuals with a diverse background, because those long-standing disparities have put them in a poor oral health and overall health status, yet to be able to communicate effectively and be able to change the behaviors to have a better outcome. The lifestyles and health belief and everything else that goes along with that fabric of diversity, the providers need to understand and work with that in order to remove or challenge that barrier. In a multicultural society such as the United States, healthcare providers need to be culturally competent to be able to deliver care to all individuals. And it's important to ask ourselves as a self-check and check our awareness, check our skills, how to be able to assess and take simply health history without offending anybody culturally, having the knowledge of backgrounds and different cultures, being able to encounter them, and also simply asking ourselves, do we want to have that kind of competency? Is the cultural competency important as a part of healthcare? Why is it important to be culturally competent and understand diversity? In a demographic landscape in the United States, cultural values and pattern of understanding gives individuals a sense of direction. By being culturally competent and sensitive, oral health providers can deliver oral health care along with overall health care and help to close the gap between oral health and overall health outcomes. Despite these assessments, obstacle to life satisfaction among elderly still exists. Personal limitation and loneliness equally affect the life satisfaction among older individuals. Additionally, reduced financial resources pose obstacles to life satisfaction. As you can see, millions of Americans of various ethnicities and backgrounds live in poverty. Overcoming this obstacle is imperative in improving life satisfaction and improving overall health in older population. In this next section of the presentation, we will be discussing the oral health status of aging population. What is the oral health status of older American? According to National Health and Nutritional Examination Survey, more adults 65 and older are keeping their teeth. Many continue to need preventive measures and management of dental problems, including but not limited to xerostomia, caries, periodontal disease, and tooth loss. With the greater life expectancy of population, xerostomia or dry mouth has increased, and it's an important and a big part of overall health issues. 96% of all adults 65 and older have cavities. 20% have untreated tooth decay. That's 1 in 5. Periodontal disease affects 68% of individuals 65 and older. Tooth loss, close to 19% of individuals 65 and older are edentulous, and as the individual gets towards 75, edentulism increases. Let's take a closer look at the 4 dental problems that we mentioned earlier: xerostomia, caries, periodontal disease, and tooth loss. Xerostomia is a side effect of many of the medications that elderly 65 and older take for variety of chronic health issues. Those health issues include, not limited to, overactive bladder, allergies or asthma, high blood pressure, high cholesterol, autoimmune disorders, neurologic disorders like Parkinson's disease, Alzheimer's disease, mental disorders like anxieties or depression, or just pain. Many of these medications, according to American Dental Association, over 500 medications induce xerostomia and dry mouth. How does dry mouth contribute to the development of dental caries? If ideal environment exists in an acidic pH, in poor oral health and sugary diet, bacteria in plaque contact the host enamel, dentin, and cementum. A patient with xerostomia lacks the protective factors of salivary fluid, contributing to formation of an ideal bacterial environment. The process of dental caries develops by the byproduct of bacterial metabolism of carbohydrates, including lactic acid and uric acid, which can lead to demineralization of enamel, dentin, and cementum. When the tooth root is exposed, cementum covering the root surface is also affected. Root caries is a major cause of tooth loss in older adults, and tooth loss is a most significant oral health-related factor affecting quality of life in older adults. In addition, removal of dental plaque becomes a more difficult challenge because of age-related toothbrush abrasion, gingival recession, salivary dysfunction, dexterity disabilities, and cognitive limitations. As can be seen in this chart, the incidence of periodontal disease varies from race to race. Regardless, periodontal disease continues to be an oral health concern among elderly. While white Americans have the lowest rate of almost 9%, African Americans have the highest rate of periodontal disease of 23.92%. The next category of dental problems that we are looking at is periodontal disease. What is the periodontal disease, and how does it relate to oral health of aging Americans? Periodontal disease is a chronic infection disease that affects the supporting structure of the teeth. The prevalence of the disease in older adults has clearly been related to the poor oral hygiene and high levels of plaque. The data from National Health and Nutrition Examination Survey has reported a significant increase in a mean recession in older adults, but a decrease in a mean pocket depth of a mean loss of the attachment. In addition, according to an article published by Journal of Dental Research in 2010, over 70% of elderly have either moderate or severe periodontitis. However, there is no major loss of periodontal attachment in a healthy elderly. Therefore, we know that it's definitely related to plaque bacteria. In summary, this graph from the National Health and Nutrition Examination Survey reviews the trends of edentulism in aging American population. While majority of elderly above 65 are keeping their teeth, the rate of edentulism increases from 13% to 25.8% after the age of 75 specifically. On average, women are to be more likely edentulous at 19.4% than men at 17.5%, and African American are more likely to be edentulous at 29.2%. In a comparison of elderly living between 1988 and 1994, those living in 1999 and 2004 were more likely to return their teeth. However, in both groups, the incidence of edentulosum was significantly increasing after age of 75. In this next section of the presentation, we will be discussing the link between oral health and other common chronic diseases. Nationally, 80% of elderly have at least one chronic disease. 52% of elderly have multiple chronic conditions. Health and safety are a great concern with this population. Every 15 seconds, an elderly is treated in an ER across the U.S. 25% of older adults struggle with non-age related mental health. According to CDC in 2012, 15 most common health concerns for seniors are as follows: arthritis, diabetes, shingles, substance abuse, Alzheimer's disease, falls, osteoporosis, depression, respiratory disease, cancer, heart disease, obesity, oral health, influenza, and pneumonia. And yet this population dealing with all kinds of health issues, 45% of them are living below poverty level. How do these chronic diseases relate to oral health? For example, in patients with cardiovascular disease, any ulceration in periodontal pocket epithelium will introduce bacteria to the blood circulation via vascular mechanism, causing platelet aggregation and a small thrombus formation, which causes inflammation. Inflammatory process is a contributing factor of pathophysiology of arteriosclerosis that leads to coronary heart disease. In a case of diabetes, data supports that first clinical manifestation of diabetes are periodontal changes. Studies also support a positive correlation between oral candidiasis in individuals with type 2 diabetes and colonization of staphylococcus in dental removable prosthesis patients or patients undergoing dialysis. Periodontal disease is severely prevalent and under-recognized in patients with renal failure. Periodic dental exam and prophylaxis and early dental treatment should be intensified for these individuals. In addition to managing patients with chronic conditions, it is imperative to screen elderly patients for cancer screening. Oral cancer is the 8th most common cancer worldwide, and the prevalence of oral cancer increases with age. Individuals 65 and older are at high risk. Oral cancer therapy includes surgery, radiation, and chemotherapy, which may be responsible for anatomic and functional changes affecting speaking, chewing, and swallowing. This may significantly impair the quality of life in oral cancer survivors. Most studies evaluate quality of life in short period within a first year after diagnosis. If detected at an early stage, survival from oral cancer is better than 90% at 5 years, whereas a late stage disease survival is only 30%. It is imperative to screen all patients for oral cancer on a periodic basis for early detection of oral cancer to prevent more invasive and surgical treatments. In this section, we will be discussing the primary and secondary oral health preventive measures. Oral health and dental care for aging population goes beyond emergency care, extractions, and denture care. Majority of dental disparities occur among elder rural adults. The single approach to improve oral health in rural elderly is to extend Medicare to oral health and attract more dentists in local communities to be able to treat and care for this population. According to Dr. Judy Jones, an ADA expert, the dental treatment must reflect the patient's comprehensive medical history and a state of well-being. For one example, patients with Alzheimer's or dementia. In patients with dementia, it is important to establish a nonverbal communication as they may misinterpret your actions. They cannot process command quickly. Therefore, they require an expert dental team that works efficiently. The best treatment for these patients is preventative oral care. What is the appropriate method to approach the elderly in a dental office? Approach the patient at eye level and within his or her visual field. Establish a rapport with the patient by engaging in affirming and simple conversation. For example, complimenting the clothes they are wearing or a jewelry like a shirt. Gentle touch should be used carefully. Remember to smile during the interaction. There are certain things we must avoid speaking with the elderly. Avoid of elder speak, a term used by describe baby talk speech. This pattern is associated with infants and pets, not older adults. Avoid speaking in a high-pitched voice. Avoid short sentences. Sing-song cadence, patronizing tone, use of collective pronouns, and avoid infantilizing terms such as baby, honey, dearie. As I mentioned earlier, the best treatment for the elderly is preventative oral care. In this section, we're going to talk about fluoride use in caries prevention and management of caries in the elderly, which is yet the best method of preventive oral care for the elderly. Many studies still support fluoride is the best method for oral care for the elderly. What are clinical applications for fluoride use? is to increase fluoride concentration in saliva, in the plaque fluid and tooth interference, in the mineral crystals fluid in the lesion. And the best way to use fluoride is on a low dose high frequency regimen, which is daily use of fluoridated toothpaste and mouth rinse. And here are various examples of fluoridated mouth rinses that can be used on a daily basis. A systematic review was published in 2004 providing moderate scientific evidence that combination of treatments involving fluoride have a preventive effect on caries in children and adolescents. However, for elderly patients, the scientific evidence for the caries prevention effect of different combination of treatment was found to be incomplete. No conclusion could be drawn regarding the evidence for combination of treatments being effective for groups at high caries risk, as the result from the identified clinical studies were conflicting. In these sections, we'll be discussing evidence-based recommendations of fluoride use in the elderly. There are three vehicles to deliver fluoride for the use of dentistry. Professionally applied fluoride method is being applied by dentist or hygienist, and that's in the form of fluoride gel, foam, and varnish. Community-based fluoride use is having fluoridated water in a community, and then home-based fluoride use is in a form of using fluoridated toothpaste, mouthwash, or even fluoride home gel. For effective caries control in the elderly, including root caries, the recommended applications are monthly applications of 22,600 part per million fluoride varnish, twice a day use of 5,000 parts per million fluoride toothpaste, quarterly application of 1% chlorhexidine varnish, and quarterly application of 5% sodium fluoride varnish, and also annual application of 38% silver diamond fluoride, also known as SDF solution. In this section, we will discuss silver diamond fluoride, SDF, in a little bit more details, as this is the newest product in a market of caries prevention and oral care. Despite of recent attention to SDF, it is not new. Human studies go back to 1966, and it was just approved in the United States by FDA back in August of 2014. Silver diamond fluoride is simply a combination of 1 atom of fluoride, 1 atom of silver, 2 atoms of nitrogen, and 6 atoms of hydrogen. This combination forms a fluoride that seems to be very effective. It with caries lesion. We'll look into that now. Let's look at some facts on SDF. The benefits far outweighs the risks, if any. It's easily used. SDF arrests over 90% caries if applied twice a year. SDF can be applied by dental hygienists in some states. It is effective in direct prevention, and it's also inexpensive. In clinical studies by Featherstone and Hartz in 2015, SDF has been shown be effective in indirect pulp capping therapy. Additionally, with increasing frequency of application, the arrested caries significantly increases. So how does SDF relate to geriatric dentistry? Older adults are very high risk at root caries, especially those that have the condition of dry mouth or xerostomia, but that we covered in depth earlier. And then second one is use of a partial dentures. One of the major problems is the poor oral hygiene due to dexterity in other health conditions that causes personal limitations. Root caries is a major cause for tooth loss in elderly population, and again, as we talked about it earlier. So SDF can be a game changer for geriatric oral care. The use of SDF has been applied to a special population with very high caries risk, those with rampant caries lesion, difficulties to treat caries lesions, the ones with lack of dental access, deficiency in conventional treatment due to behavior and medical management. That includes patients with cognitive decline and developmental disabilities. Here is one of the best examples of the application of SDF. This case is a 65-year-old cancer patient with severe xerostomia and cervical caries treated with silver diamond fluoride. You may ask, is SDF safe? According to Horst studies, the margin of safety is referred to as very safe, as long as it is not used on individuals with allergy to silver. Laboratory studies show the lethal dose of SDF is 520 milligram per kilogram via oral administration and 380 milligram per kilogram via subcutaneous administration. What we use in dentistry is drops, and one drop contains 9.5 milligram. SDF may be treated 5 teeth. So far, no adverse incidents have been reported. Little more on SDF safety. It's important to say that SDF has been used in other countries like Japan, New Zealand, and Australia for many decades. In Japan, no adverse health reaction reported over 80 years that have been using SDF. Interestingly, black teeth created by SDF was regarded as a sign of a beauty until the end of the 19th century in Japan. How should I apply SDF? First, standard oral prophylaxis should be completed. Then, isolation and protection adjacent soft and hard tissue using cotton rolls, gauze, Vaseline, and suction. Then apply SDF using microbrushes for 2 or 3 minutes. Then rinse the SDF with water and suction. Be sure to consider pulp effects on deep caries. It is not recommended to use SDF on deep carious lesions to the pulp. So what are some legal considerations to use SDF? SDF is approved by FDA as a Class 2 medical device and prevent and treat dental caries. It is treated the same as fluoride. However, it has a different ADA number and it is recommended to use a consent form because of staining. Here are 2 examples of consent form for SDF. One is from UCSF Dental Center Informed Consent Form for Silver Diamond Fluoride, and the other one is from UT School of Dentistry for any risk related to SDF. Why oral rehabilitation of geriatric patients is important? Much of the joy of life comes from eating the variety of food one wants to eat. Patients talk about looking forward to biting into that juicy steak as they are going through the process of dental work. Oral rehabilitation must be directed to patients' masticatory efficiency because it is a big part of improving quality of life in the elderly. What are some of the objectives in geriatric oral rehabilitation? Existing dental treatment may be used as a guide for future needs. What it means is, whatever we treat patients today, we have to keep it in mind where this patient is going to be in 5 years. And usually for elderly, dental treatments that require high maintenance is not recommended, only because maybe the patients 5 years in the future may not be able to do that. Because of that, we must take time initially setting priorities to develop a treatment goal for the patients and caregivers, because there will become a time in the future that caregivers will be a big part of their oral care and home care. We must recognize possible effects of overall health issues and medications and develop a sequence plan, easily modified if needed. We can make the treatment plan in phases and complete phase 1, complete phase 2, and as patients' overall health changes, we can modify those phases and work with them, treat the patient as a whole and not the mouth only. Emphasize the value of preventive measures and reinforcement of home care and good oral hygiene, which is the base of succeeding any dental treatments. As we create a treatment plan for geriatric oral rehabilitation, There are four major domains that we have to follow. They are the four domains of subjective and objective needs. Those four domains are function, symptoms, pathology, and aesthetics. And as you can see, aesthetics is no longer the number one priority in the elderly. Function is, they have to be able to chew. They should be able to chew painlessly, and they may not have any infections in their mouth. And of course, at the end, things need to look reasonably aesthetics. Maintenance of dental prostheses is a big part of overall rehabilitation for the elderly. Complications relate to use of resin-based removable appliances require functional and biological maintenance, especially in patients at high risk, like patients with chronic illnesses such as cardiovascular disease, diabetes, and digestive diseases. The reason for that is if the removable prostheses don't fit right and they're not cleaned right, patients with diabetes that are their wounds don't heal quick, or patients with cardiovascular disease that their system is very sensitive to bacteria, and patients with digestive system, lack of maintenance can be damaging to their overall health. Dentures may initially be comfortable with individuals' needs. However, through time, environment can cause tissue injury, which is inflammation, hypoplasia, ulceration, and infection. It is imperative for dentists to have collaboration with other disciplines, health providers regarding the individual's overall needs and their overall health. For example, caregivers, physicians, nurses, even therapists, speech therapists, physical therapists, when they see something that patient is uncomfortable in their mouth, or if they see a lesion, or if there is something that needs the attention of a dentist, that collaboration will make everything easier for the elderly in a process. Positive aging and having quality of life in an older age has a lot to do with healthy oral health. Poor oral health and uncomfortable mouth affects the nutrient intake and affects the overall health of the elderly. So in this section, we're going to talk about geriatric nutrition. Unfortunately, malnutrition among elderly too often it goes unrecognized. Malnutrition presents at least 2 to 6 clinical characteristics, which could also be associated with general wasting or cachexia, usually linked to chronic illnesses. Insufficient food intake that can be due to many reasons. One of the main things, obviously, uncomfortable oral health, any pain or ineffective, inefficient teeth arrangement, anything that leads to patient not be able to eat, minus nutrition requirement, which is the nutrients that body needs to function properly, leads to malnutrition. Many problems of elderly, such as anorexia, depression, fragile bones, fractures, insomnia, and poor vision and hearing, results from inadequate diet and nutritional deficiencies. Be sure with your patient to observe and document any kind of weight loss over time, loss of muscle mass, loss of fat mass, fluid accumulation, and measurable diminished grip strength. Why older adults are at high risk for malnutrition? Alteration in absorption due to changes in gastric secretion, which limits absorption of iron, vitamin B12, sometimes constipation, and other changes place some elderly at a higher risk for malnutrition. Malnutrition may occur by changes in consumption and loss of appetite due to sensory changes, decreased sense of taste and smell. Sometimes ability to access food, like going to grocery shopping, especially those that they live in a climates that there is either extremely hot or extremely cold, ice and snow, usually stops these poor people to be able to go to the store and buy food. Loss of vision and hearing leads to diminished ability to purchase and preparing food. Economic hardships and depression may increase consumptions of comfort foods, which are mainly empty calories and food with very high carbohydrates. And last not the least is oral health status and dental problems, toothaches, lesions in the mouth, ulcerations, anything that prevents them to be able to masticate and chew. Unfortunately, malnutrition among elderly is regularly underdiagnosed. Malnutrition is both a cause and a consequence of poor health. 2 to 16% of elderly living in communities, of course depending on if they're living in at home or nursing home facilities, are deficient in protein and good calories. If minerals and vitamins included, malnutrition in elderly may rise to 35%. As it was mentioned earlier, malnutrition is both a cause and a consequence of poor health. The prevalence of malnutrition is increasing in this population and is associated with decreased bone mass, leading to osteoporosis and sarcopenia. Metabolic changes, for example, a decrease in gastric acid secretion, limiting absorption of iron and vitamin B12, and constipation. Reduce cognitive function. A lot of people can have dementia, even though sometimes is reversible dementia, but malnutrition can lead to a type of dementia. Poor wound healing because of lack of nutrient that it needs for a wound to heal, like certain protein. Delayed recovery from surgery. Higher hospital readmission rates and mortality, which can easily be prevented. The importance of nutritional status are most recognized in conditions such as cancer, heart disease, and dementia. Malnutrition greatly affects immune system, metabolic pathways, organs, pretty much the whole body in a negative way. Some of the malnutrition outcomes are nutrition-specific deficiencies, protein deficiency, vitamins, mineral-specific deficiencies, systemic problems, increased risk of infection, increased healthcare cost, dental-specific problems. And looking at every single of these items, you can connect it with some sort of malnutrition. And malnutrition is not always not eating at all. Sometimes it's just eating the wrong things. Some things that, the food that don't have nutrients in them. And we know that with patients that are in a high caries risk, if we look at nutrient analysis, we can find a lot of carbohydrates and sugar in it, and so on and so forth. Micronutrients are important in diet, and the deficiency of them may lead to malnutrition or undernutrients in individuals. They include vitamins, minerals, trace elements, phytochemicals, and antioxidants. Trace elements include metals only required in a very small amount in human diet, as they can be toxic in excess. They can act as a catalyst in enzyme system. Phytochemicals are believed to protect cells from damage that could lead to cancer. They are nutrient chemical structures to help stop carcinogens from attacking cells. They enhance the immune system. Antioxidants such as vitamin C, E, and beta-carotene protect cell damage caused by free radicals, which appears to be a major contributor to aging and diseases like cancer, heart disease, decline in brain function, and decline in immune system. Macronutrients. There are three major macronutrients in our diet. They are carbohydrates, fats, and proteins. Oral health status affects nutrition status, and nutrition status affects oral health. Oral health is a significant factor for the process of aging and well-being of geriatric population. It may be a fair statement to say the mouth is the gateway to overall health. Again, as it was mentioned earlier, there are many reasons and causes for malnutrition. It's internal systemic issues, is mental, behavior, financial. It's a multifactorial condition that it can be prevented. It is a failure that must be addressed in the geriatric population. Individuals in healthcare communities are at increased risk for oral health problems as well as nutritional health problems. We cannot prevent aging. Aging happens, and as aging happens, there is less coordination in swallowing. It causes dysphagia. Tissue is more vulnerable to injuries, pressure, burns, cuts. Elderly are more prone to osteoporosis, and all these incorporate into decreasing quality of life. Yet, positive aging within the limits and quality of life to a degree as we get older. Like all the facts we talked about, nutrition, preventing preventable health problems, oral health problems, mental problems, anything and everything that can be prevented, it will increase the quality of life within the limitations of aging. It's all about positive aging. Dysphagia or swallowing disorder is a part of natural process of aging. Regardless of etiology, as we get older, as muscle tone changes, some dysphagia happens. However, in some patients with some chronic illnesses, the problem is exaggerated, and issues like Parkinson's disease, like MS, dementia, and other end-life disorders. Generally, people have a certain pattern of chewing strokes before swallowing. As a practitioner, pay attention to that with your patient. Strokes and neuromuscular diseases such as Parkinson's and MS may alter swallowing, changes that pattern of swallowing. Therefore, it is important to minimize reclining the patient to prevent patient's obstruction airway, and especially during the fabrications of prostheses or placing restorations. Let's look at a statistics on elderly that are at high risk for malnutrition. In the United States, 3.8% of population aged 75 to 84 and 15.4% over 85 years old live in healthcare communities. 15% of this group depends on others to eat. 39% of residents depend on others for daily living activities. Looking at these numbers, 37 to 62% of residents are at high risk for malnutrition. That's a big number for not recognize that a lot of elderly are at risk for starvation. This table outlines the function and outcome of damage to cranial nerves of chewing and swallowing process. Cranial nerves 5, 7, 9, 10, and 12 are the main nerves that facilitate chewing and swallowing. So if the individual has a stroke or a heart attack that these nerves are damaged, it puts them in a very high of malnutrition because they simply cannot chew or swallow. Here are some voluntary and involuntary muscles that as a group function into chewing and swallowing, and every single one of them or a group of them, when it's damaged, it affects the patient's function with eating and nutrient intake. Now that we are aware of the problem, in this section we're going to discuss to see if the dental care providers have adequate training to be able to see this population, these elderly that are changing the landscape of oral health in the United States. Are we preparing the future oral health providers properly trained and knowledgeable on older adults' oral health care. Statistics back in 2013 shows 89% of dental schools provide their pre-doctoral students, that's DS students 1 to 4, with some education in geriatrics. That means some courses, some lectures, some basics. 22.6% offer clinical training specifically geared towards older adult care, where 69% includes geriatric components in their general practice, residency, or advanced education in general dentistry. That usually is in part of GPR and AGD programs. Only about 23% of schools offer a continuing education course in geriatric at any given time. Although personally, I know that since 2013, schools are growing more towards elderly education, but we have a long way to go. But it's good news. The issue has been acknowledged, and we definitely are teaching our new dentists in the future how to deal with them. What are some potential educational barriers? Lack of geriatric dental training incorporated into dental curriculum in dental schools. Lack of faculty members to teach those courses. This can easily be traced to lack of CODA standard for requiring treatment for medically compromised older adults. Lastly, the lack of dental students' access to medically compromised geriatric patients. In this section, we will be talking about quality of life and positive aging associated with oral health. In many situations, a good oral health is the missing link to a good quality of life for the elderly. Many clinical epidemiology studies show the oral health of elderly is poor. And also studies are showing when the oral health of the elderly is poor, then they tend to isolate and not get involved with social activities, which leads them to depression and other issues. The missing link is educating caregivers, multidisciplinary collaboration in providing proper oral health as a part of comprehensive care for positive aging and quality of life. According to National Institute of Dental and Craniofacial Research, orofacial pain and oral infections negatively impact older adults' quality of life and nutritional status. Despite the importance of oral health for elderly, it still remains a low priority for many caregivers. Knowledge and perception of nursing staff plays a crucial role in improvement of these patients' oral health and quality of life. In summary, as of today, there is no basic oral health guidelines for the elderly. Dental caries is still a public health problem for most elderly. The subgroups experiencing even greater barriers accessing dental care, especially those that are in lower socioeconomic status, older adults with dementia, those who are homebound and institutionalized. Perhaps the situation will not change until Medicare recognizes oral health as a part of overall health. If you have any questions about this course, please do not hesitate to contact me via my email or phone number. We have come to the completion of this CE course. There is a short quiz for you to take. 90% is required to pass this course. Thank you for your time.